many who do arthroscopies. I do all. Not now, but from day one of my practice, which is 22 to 23 years, I do arthroscopy, I do high tibia osteotomy, and I do unis. So I am in a special privileged position where I can share my experience. HTO is one of my favorite surgeries. It's a combination of what I learned from great Dr. K.T. Dholakia, K.V. Chobal, and David Dandy. It's a combination of all three. I take about 30 to 40 minutes to finish the surgery, and it's a great operation. But until you come across something which you love even more, which is the Oxford Uni knee replacement. Why do I say that? We all have experienced problems with HTO. One is it can be unpredictable. So you do same technique in 10 patients, maybe 6 or 7 are reasonably happy, but 3 are unhappy. And we are unable to assess or find out why this fellow is unhappy. It has a prolonged recovery period. You have to be non-weight bearing for some time, even with the modern techniques. And the old-fashioned plaster does take 2-3 months for the osteotomy to heal. The relief of symptoms may not be complete. We all have come across patients who keep telling us, "Nahi sahab, thoda to abhi bhi dukhta hai yahan pe." And the survival of an HTO is an issue. It can last for 7-8 years. Now, I have been doing uni knees, only Oxford knees, for now more than perhaps 10 years or plus. And before that, I was exposed to the fixed bearing uni knees. We all know the problem with the fixed bearing is the stress riser effect of point loading on these, because the contours are not matching of the femoral component and of the tibial component. So, if we ask ourselves a dream question, is it possible to have an implant or a prosthesis which allows sliding, rolling, has a large area of contact which are matching, that generates only compressive forces and no shear forces, and allows the surrounding soft tissues to restore the normal tension of that knee? Is it possible to have all this? And that translates into the design of the Oxford knee. It is a spherical femoral component with exactly matching upper surface of the poly, which is matching the femur. So it's a 100% contact surface area. The undersurface of the poly is matching that of the metal tibia. So it's a conforming surfaces. So no point stress riser effect. And it is an unconstrained poly. So effectively, there should be no wear. And I'll show you the data. So it's the only UKR which is fully congruous and has a mobile bearing poly. And this credit goes to John Goodfellow and O'Connor 34 years ago. So it's not a new operation. It may be new to our setup, our scenario, not new anymore. It's more than 10 years for me. It was first used in 1982. That's the unicompartment knee done in 1982. Thank you, Oxford team, for sharing the X-ray with me. The concept. So why is this such an attractive concept? What is it which attracts me to this design, this implant? If you look at this graphic picture of a meniscus intact knee and see how the load is distributed uniformly. And if you do a meniscectomy, it leads to point stress riser effect instead of a uniform contact surface area. And that's the anatomic specimen which is telling you how the menisci function in load bearing. And the menisci also have a certain amount of mobility. I'll show you a beautiful MRI which shows the menisci are mobile. And this is what the Oxford knee does. It is translating the same concept into reality. Conforming surfaces, only compressive forces, no shear forces, therefore very little point stress riser, and hence, if you look at the poly wear rate, it's almost zero. It's not new data. This is Oxford team data. It is 0.03 millimeters per year. So it will take 30 years to wear off 1 millimeter. You can imagine how, if you imitate anatomy, how effective it is. So it will take 33 years to wear off 1 millimeter of poly. And we all know that the main problem today, even today, with the TKR is a poly wear. That's eliminated. Now, what I find most interesting and attractive is that the design of this implant is unchanged. Whenever the implant design keeps changing, it means they are facing problem. This fundamental design, phase 1, phase 2, phase 3, we are at the moment in phase 4. It's called microplasty, which I'm using for a year and a half now. But all the 4 phases, though the slides only show phase 3, the basic concept design is same. What has changed is only instrumentation. In the bracket, if you see, what has changed in phase 1 is, 2 is the mill has changed. Little bit of instrumentation. More number of sizes were available. And phase 3, the instrumentations changed further for minimally invasive surgery, MIS. But the concept has not changed, the basic design has not changed. So what is the indication? How do you select? You got to be very strict with your selection criteria, otherwise you'll not have a good result. You want bone on the medial compartment, which means full thickness cartilage loss on the medial compartment. You want intact cruciates. And a varus deformity which is correctable. The moment you have a fixed varus deformity which necessitates release of the MCL, it's a contraindication for Oxford knee. So the varus has to be correctable clinically. In your consulting room, you can check that. And the lateral compartment has to be good. Patellofemoral need not be perfect. So what is this condition known as anteromedial disease? And I'll explain to you how this occurs. With an intact ACL is what you end up with, anteromedial disease. So that's the femoral condyle, medial and tibial plateau, the one with lines. The green is the preserved cartilage, and the red or the pink is the loss of cartilage. You can make out that this is a medial compartment osteoarthritis with an intact ACL by plain X-ray. I'll show it to you. It's more reliable than an MRI either. ACL intact, you get anterior wear. ACL intact. If the ACL is gone, the tibia keeps sliding posteriorly, so the wear extends posteriorly. So whenever you do a total knee or a uni knee, just look at the cut surface of the tibia. Don't be in a hurry to do the next case. Have a look at the cut surface of the tibia. If the ACL is intact, the articular cartilage is worn out anteriorly. Posterior part is intact. I challenge you, go home and see next TKR that you do. And if there is a gross ACL loss or absence or an unstable knee, then the wear extends posteriorly. So whenever you have an intact ACL with osteoarthritis, you will have an anteromedial disease. This is what I mean by full thickness loss on the medial side, bone on bone. Lateral side has to be intact. You can do a valgus force X-ray and it shows that the lateral side is intact. You can give a valgus force and do a plain X-ray. Sufficient, you don't need arthroscopy. There are 2-3 studies, one by the Oxford team themselves, that does arthroscopy help in selecting patients, not required. Plain X-ray is enough. Best shown by plain X-rays. If you have a little bit of osteophyte on the lateral side, you can safely ignore it. Doesn't make any difference on the result. But if you have an ACL deficient knee and you do an Oxford UKR, it will fail. There it is. So let us see what are the results in the world with people who have been doing it for 30 plus years. So this is a 10-year survival rate. It's the designer series. The people who designed it, they are going to report good results. Let's think that they are biased. 98% survival at 10. That's David Murray. Then you have another series, independent series. This was the Swedish people, Sward and Price. 420 Oxford, 94% survival at 15 years. That's the graph. Excellent results. 135 knees. Our own Rajshekhar from Coimbatore, along with Smith, 2004, 94% survival at 10 years. 200 Oxford knees, 99% survival at 10 years. Keys from Macclesfield. So phase 1 and phase 2, if you look at the series, is all in 90s. Excellent results. Bearing survival. What happens to the bearing? So these are all excellent bearing survivals at 15 years. Dislocation rate. In between there were problems with dislocation because of not proper soft tissue balancing. But the dislocation rate, after the slight modification in the poly, there's a little ledge, so it stops the poly from spinning. 0.4% dislocation rate of the poly. Knee score, Hemant Pandit, our own Bombay boy, has done a lot of work in Oxford. These are the knee scores at 2 years, excellent results, range of movement nearly full. I'll show you some videos. So what is phase 3, which was the last one? Now it is microplasty phase 4. It had more sizes. You could do by a very small incision. Now my own series, which is getting published perhaps in a month or two, and this is based on phase 3, and I suggested from this study that there should be a jig to link the femoral component to the intramedullary rod, and that is what has been introduced in the microplasty set, which is phase 4. So I have 70 patient study between 2007 and 11, one died, so typical age group scenario, average age 60. Now what I did in this study was, we measured 4 angles. The femoral component, varus valgus, flexion extension, varus valgus, flexion extension, tibial component, varus valgus, flexion extension. Mind you, this is phase 3 instrumentation. And we measured of all the Oxford knees. And this is the parameter that the Oxford team has recommended, that you should insert the implant with this much error, not more than this. So error of 10 degrees in varus valgus, error of 5 degrees. And we said, let's have a look at, with phase 3 instrumentation, how we end up putting the implant. And if you look here, it is a bit shocking. That perfect, which is Inlier, as recommended by the Oxford team, only 58%. One angle, out of 4 angles, you put one angle wrong, was 35%. 2 angle outlier is 4%, and 3 angle outlier is 1.49. Now, this is all individual implant angles, those who are interested. If I summarize this, the outliers were primary femoral prosthesis. That means in phase 3, it was difficult to put the femoral component perfectly in all the patients. Why? Because the femoral jig was not linked to the intramedullary rod. It was by eyeballing. Those who have done Oxford knee knows, Dr. Malan is here, he knows about it. So therefore, from this study, but if you look at the clinical outcome, if you are inlier or one angle outlier, no impact on the scores, on the outcomes. Statistically, no significant. But if you are 2 angle or more, 3 angle outlier, the result drops. 1 angle outlier doesn't matter. HSS score, and that is Oxford knee score. Inlier, 1 angle, no difference. 2 angle, 3 angle, problem. So therefore, what we recommended was, this is the summary, inlier, 1 angle, 94%. So with phase 3 instrumentations, you'll be able to put the prosthesis either perfectly or just 1 angle off in 94% of cases, but 2 or more in 6% you may go wrong, and therefore the femoral jig, and therefore the microplasty instrumentation, where they have linked the intramedullary canal to the jig, and therefore you can put the femoral component more precisely, more accurately using that link. So what is the conclusion of my own series, my own experience? It's a successful operation, 97 patients satisfied. Implanting the femoral prosthesis, be careful. Malposition, if you end up in more than 2 components, 2 planes, you may have a poor outcome. Look at the result, 54-year-old female, normal knee, operated knee. In spite of my saying no, she sits cross-legged and sits in all possible ways. Another gentleman, 68, nearly full flexion, sitting cross-legged. So phase 3 results, this were published recently, 530 cases. The results of TKR following a failed UKR are same as a primary TKR, and therefore a human knee can get a life of almost 30 years, say 15 years UKR and 15 years TKR. But don't do an UKR, contraindications, if you have a flexion deformity more than 15 degrees, varus which is too much and not correctable, which means you'll need a MCL release. No, Oxford is contraindicated. If the lateral femoral condyle is showing signs of articular wear. But what you think could be contraindications, but are not contraindications, patellofemoral OA, except if you have a lateral facet gone with tilt, I don't do an Oxford UKR, I would do a TKR. But medial compartment, because pure medial compartment OA is theoretical, it never happens. When you see a patient, they will have some amount of patellofemoral. And if it is medial patellofemoral, you can ignore it. There is no impact on the result. There is a big study of 100 UKR Patellofemoral not involved, patellofemoral involved, and compare, no difference, as long as it's some medial facet involvement. Obesity, not a contraindication. Age, not a contraindication. I have a 78, 80-year-old, but classic medial compartment suitable for Oxford, I will do an Oxford. So what is my protocol? Where do I fit in all this? Because HTO I'm in love with. If less than 50, I see this kind of an X-ray, I would do an HTO. More than 50, Oxford UKR. Only if there is a very significant mechanical symptom of a loose body locking or things like that, then I will do an arthroscopy. So in other words, these three modalities, they complement each other. They don't compete with each other. So I will not put the title as HTO versus UKR. I would do HTO in some set of patients and an Oxford UKR in another. It may be the only choice. HTO may be the only choice in less than 50. I would be reluctant to do any kind of implant. Some of the examples of Oxford